Hello, and thank you for listening to my presentation. I will be talking about a project that I conducted over the past year on inhibition of CSF-1R to enhance the efficacy of radiation and reduce immune suppression in glioblastoma. Glioblastoma, or GBM, is the most common malignant brain tumor in adults. It is an invariably lethal tumor with a median overall survival of less than 2 years. Treatment involves a maximal safe resection followed by adjuvant chemoradiation. As illustrated here by this MRI, it is a highly infiltrative tumor. This infiltrative nature makes it virtually impossible to completely resect, and there are always microscopic cells left behind. As a result, local recurrence is the main cause of death in most patients. Unfortunately, GBM cells are quite adept at creating an immunosuppressive tumor microenvironment. The body's immune system in most cases mounts an immune response to cancer cells. In fact, targeting cancer cells with radiotherapy often exposes antigens and helps augment the anti-tumor immune response. Many studies have shown that in GBM, radiation leads to a surge of pro-inflammatory cells that are capable of killing tumor cells. However, GBM, like many other cancers, is able to create a counter response that creates an anti-inflammatory environment that helps tumor cells proliferate, escape the immune system, and promote radiation resistance. As illustrated here on the right, GBM cells recruit a myriad of immunosuppressive cells through multiple mechanisms that are beyond the scope of this presentation. However, these cells include Tregs, otherwise known as regulatory T cells, as well as immunosuppressive macrophages called M2 macrophages, all of which suppress effector T cells whose job is to kill tumor cells. Most of the currently commercially available immunotherapy agents are called immune checkpoint inhibitors, and they target the Treg pathway shown here. Unfortunately, two large randomized trials have shown disappointing results early on with these drugs in GBM patients. Emerging evidence shows that the failure of immune checkpoint inhibitors is likely due to the targeting of the wrong cells. While Tregs play a major role in most solid cancers, preclinical and clinical studies have found M2 macrophages to be the predominant player in GBM. Prior preclinical studies have found a factor called CSF or colony stimulating factor to be the major pathway by which GBM cells are able to recruit M2 macrophages. This factor signals through an inhibitor called CSF-1R. Two preclinical models previously have shown that inhibition of CSF-1R was able to reduce M2 infiltration within GBM tumors. In fact, there are two ongoing clinical trials testing the efficacy of CSF-1R inhibitors as a monotreatment in a variety of solid tumors, including GBM. Putting together all the information presented here, we hypothesized that combining radiotherapy with a CSF-1R inhibitor would enhance the impact of radiotherapy on GBM and augment the radiation-induced immune response. To test our hypothesis, we studied the combination of radiation and a commercially available CSF-1R inhibitor called BLZ-945 in an orthotopic mouse model as illustrated here. We stereotactically injected GBM cells called TRP into the brain of immunocompetent mice, waited 2 weeks for the tumors to form, and then administered 3 doses of radiation with and without the inhibitor BLZ. Mice were followed and sacrificed if they developed neurologic deficits or lost over 20% of their weight. We had 4 treatment arms, a control group treated with vehicle alone, a group treated with BLZ alone, a group treated with RT alone, and a group treated with BLZ and RT concurrently. 2 weeks after starting radiation, we performed MRI imaging of mouse brains, and as illustrated by these images on the left and the quantitative tumor volume measurements on the right, tumor growth was substantial in the untreated mice or mice treated with BLZ alone. RT alone was able to significantly inhibit tumor growth, but the combination of BLZ and RT was the most effective, with tumors almost completely disappearing as shown here. This is the most important result of the experiment. This is a Kaplan-Meier curve that shows survival for each treatment arm. All mice in the untreated and BLZ alone treated arms died within 37 days. Radiation alone prolonged survival significantly, but still mice died within 2 months. The combination arm, however, was able to achieve long-term survival, and nearly 75% of the mice were alive at 4 months, which was the study's endpoint. We also harvested the brains of each mouse at the time of death and used flow cytometry to look at a variety of immune cells. The most significant finding is shown here. Nearly 40% of immune cells within the tumor microenvironment was comprised of M2 macrophages. This percentage was significantly increased in response to radiation, which supports the notion that these cells mediate radiation resistance. The addition of BLZ was able to reduce the degree of M2 infiltration around the GBM tumors as shown in the second and third box plots. The reduction was most pronounced in the combination arm. In conclusion, in a preclinical model, CSF-1R inhibition was able to reduce M2 polarization and infiltration within the GBM tumor microenvironment. CSF-1R inhibition was able to enhance RT efficacy, seemingly by reducing anti-inflammatory cell infiltration. These results are promising and have translational significance. CSF-1R inhibitors are currently in clinical trials and have been found safe in humans. At least a pilot clinical trial of concurrent administration of one of these inhibitors with radiation in GBM patients warrants consideration. Thank you for listening to my presentation.